This session today is about the politics of health, and we are going to use the gift and the brilliance of Katerina's work and experience, and also Asiel's work and experience to help us explore what that means. I too would also like to acknowledge the traditional owners of the land, and then this NAIDOC week, as in all weeks, say that this was and always will be Aboriginal land. And in the spirit of NAIDOC week and embracing the opportunities, I want to say, Katerina, how much I loved your book, and I love the way that it used the personal and historical and the research, the evidence-based to really drive home, I think, you know, the lived experience of a woman trying to negotiate her health, her identity, her story, and her agency, I think. So that's what spoke to me as a person that works a lot with women's health and with the health community. But I really want to start by asking you, Katerina, what made you write this book?
Thanks so much, Nikki and Kit. I'll just start by saying a brief visual description of myself. I'm Katerina. I am a woman with short hair wearing a white shirt in front of a quite colourful bookshelf. So for your question, Kit, I started writing the book as I was experiencing my own symptoms and the process of diagnosis, which was eventually non-epileptic seizures, which sits within the perhaps negotiation between psychiatry and neurology. And during this time, as I think a lot of us who are navigating a new experience within their body, I was really eager, hungry for answers, and I went at first to a lot of medical journals and conducted a lot of reading. And then I found that, as well as therapy and all of those medical interventions, the thing that really sat with me was the shared history of women experiencing mental illness and the strength of them and the power that their lives held for me as a portal to understanding how I can negotiate my own life and advocate for myself as they did.
Yeah. Okay, perfect, Katerina. And Asiel, I really want to acknowledge your history and your lived experience and your profession as a medical practitioner in this conversation. And I really want to ask you now, well, with the work of Katerina and the book Hysteria, what did you take from it with all of that rich lived experience?
Yeah, of course. I might also start by acknowledging the traditional lands of the Woiwurrung people of the Kulin Nation, from which I am transmitting live today out in Boule, Quebec, which is the Kulin name for Brunswick, in cloudy Victoria by the looks of it. I am currently wearing a traditional Mexican huipil, which is a traditional dress that is worn in Mexico. Lots of floral print and lots of vibrant colors, with a background of a lovely Frida Kahlo wall in the wall. Now, reading Katerina's work was such a privilege because as a health professional, the way that we interact with our patients is very much through a medical lens. So we always tend to focus on symptoms, and particularly for conditions which don't have a clear diagnostic boundary. A lot of it is spent gathering, collecting information, in a way asking about the experience, but having that experience filtered through that diagnostic lens. So Katerina's work was so important for me because it really opened up a much vulnerable, braver space that we usually don't have the opportunity to talk about with patients. It delved into those nitty-gritty aspects of lived experience that perhaps in a medical setting sometimes ironically gets lost. And what was also really fascinating was the historical connection between how the medical profession and the medical lens and the medical discourse has treated women or people of marginalized gender minorities in the past. And really the only way that they can access that lived experience is through this sometimes violent medicalized lens.
Thank you. And the last word, the last sentence that you used, it was just to make sure I understood that. You said the violent medical lens. Is that right, Asiel? Yeah.
Yeah, that's right. And what I mean by that is that, for people who don't neatly fit into that lens, this impetus for self-advocacy and constant fight to be heard in ways that perhaps the medical profession doesn't have a good framework for listening to is what I mean. And the silencing of some of that other lived experience, or the pathologizing of some of that lived experience.
Very powerful. I want to thank Asiel and Katerina for modelling being mindful of the lived experience rather, and I want to just apologise that I haven't given an audio description of me. So Asiel and Katerina, if you're okay, I might just do that now. So my name is Kit, just to be clear about my voice. Also happily middle-aged greying a woman. I'm wearing a green dress, although you can't see that because I'm sitting down. Behind me, I have a bookcase with lots of books, but perhaps not as colourful as Katerina's. And in the background, I have a cello case as well. I might then go on to ask you both a kind of a common question and invite anyone to start first. Maybe Katerina, I actually would be really interested in your perspectives on this. We are at the Feminist Writers' Festival, so I want to ask you, what does feminism as a writer mean to you?
That's really interesting to think about it as a lens through a writer, because writing is often about voice. And to me, I suppose feminism is the same, but within that, being mindful of when you are speaking, who you are speaking over, whose voice you are lifting to the front, and not mediating that voice through your own lens, but allowing that voice to speak for itself and self-determined ideas. So I think feminism and writing has the kind of relationship where it can overlap in beautiful ways, and then in some ways it can swallow up that sense of community, because we, traditionally see a writer as someone who is solitary. I hope that messy answer makes sense.
I think it was
Asiel thinks.
Incredibly good. Yeah, Asiel, I know you, like Katerina, are both a reader and a writer, but if you don't mind, I'd really like if you could to answer this from the perspective of being a reader. Do you think there is a thing called a feminist reader, and what do you think that means? What's that mean for you?
Very good question. And from my perspective, let's say take what I bring to kind of feminism, or what feminism brings me, I don't know which way it goes, but this idea of intersectionality, and to me, feminism is always intersectional, not only because of my lived experience, but also because to me, it's a commitment to constantly do better and constantly try to explore perspectives that I haven't explored in the past, or critique the spaces that I'm working with in new ways. So to me, kind of bringing a feminist reader perspective into a work is to take those considerations in mind, be open to what the work is sharing with you, and use it to critique the broader kind of structure that we're talking about. So in this case, it's the medical system. So I suppose in approaching Katerina's work, what I took from it was very much a feminist critique of the profession that I'm in, kind of on a day-to-day, and how that kind of comes to bear.
Thank you. I want to now, if I can though, in deep dive, I guess, into Katerina, your book, if I can. One of the ideas that emerge, I think, for me, is when you draw. There's so many, but there's a moment where you start to draw upon the thinking of Virginia Woolf. And you tell a story about one of the great conversations you have with your father, and you think of Orlando. And I wanted to know from that sort of feminist perspective, maybe from what you talked about before, or more from, how do you think, or what's your experience tell you about how our health system interprets difference, different behaviours, different feelings? And I think what for me, I saw, that interpretation is a form of madness, to be diagnosed, and the history of that for women. So I was just wondering what you were trying to do with that, the drawing upon the story of Virginia Woolf.
Yeah, well, I think she is, certainly for my father, she was a reference point to discuss around mental illness and how to live and write well. Perhaps not the best reference point, but she had a magnificent life too. So I think that idea of diagnosis is a really complex one, because it is equally both a gift and can be a frustration. Mm. So as somebody who has intersecting diagnoses of mental illness, I can say that when I was, as an adult, diagnosed with OCD for my childhood, that gave me a lot of insight and relief, and it allowed me to tap into a community where I felt heard. So that was an incredibly positive experience, whereas being diagnosed with non-epileptic seizures felt like a non-event, because there was not necessarily anywhere to go post-diagnosis. There wasn't clear structures of care, because there is not much known about the illness. So I think the layers of diagnosis are as complex as the individuals who are diagnosed. Mm. But within that, I think the thread of how diagnosis comes about, if the patient is listened to throughout that process, if their own ideas about what they are experiencing are listened to, all informed that experience and how positive it can be.
Katerina, thank you. I keep hearing, Asiel, if I might turn to you on a similar idea, I keep hearing this idea of listening and silencing and speaking over. And again, I want to go back to that question of the feminist perspective on our health system. What's your experience of that health system, which I need to acknowledge you've written so fully about, but what contribution do you think we need to be thinking about there?
I think from a historical perspective, I mean, medicine has been very much kind of a patriarchal kind of structure from the very beginning, which means not only that certain people's experience and views are valued over other people. And I think what really came through in Katerina's book is almost the way that, figures in the past around psychiatry and neurology have used their patients' lived experience to kind of further their own ideas or career in a certain way. Sigmund Freud being the most kind of obvious example.
Which Katerina does refer to, yeah.
Absolutely. And even if we think about more recent kind of medical writers, like Oliver Sacks, the way that people's experience are used can sometimes be a little bit problematic. Mm-hmm. So to me, what kind of comes through, and what the thing that we have to challenge, and something that I constantly have to work towards, is making sure that we're discussing the lived experience on the patient's terms. And I'm just going to kind of shift the conversation a little bit towards trans and diverse kind of people, because historically it's just been viewed through such a pathologized lens where your own lived experience of gender has been essentially described as an illness, when in reality, you know that that's not the case. And I think that the way that I've tried to shift a lot of that kind of in my practice is move away from those pathologizing frameworks into more of a validating and affirming framework, where we focus on what brings you gender euphoria, instead of asking, what are the points of dysphoria? What are the ways that I could help you affirm your gender that feel comfortable for you? So rather than me putting a pathologizing medical lens on it, it's very much about listening to what the patient is talking to you about, and respecting that lived experience and moving on from there. Now that might not apply in all areas of medicine, and particularly mental health, it's such a kind of a problematic framework for medicine, because if we think about other areas of medicine, there's a visual pathology there. You can see, the injury, you can see the disease, even at a microscopic pathological level. But when it comes to psychiatry and mental health, it's a lot more nebulous. It's a little less well-defined. And it's a lot more influenced by the way that we talk about societal discourses and societal structures around it. So asthma is going to be asthma, here or in Mexico. What's going to be different is, the way that people access care there. But depression is going to look very different here to how it looks in Mexico. And I don't think our medical systems have a really good way of contending with that, or thinking about that, or reframing that in a way that it actually works across multiple domains. Bit of a ramble for you.
No, I want to pursue that though. I want to get us to think about, in light of Katerina's book and in light of the reframing, the pathologizing framework, I want us to talk about access. I think my work as CEO at a women's health service, good rant, says Sally, is to the issue of access. If feminism is absolutely, I think, for me, intersectional, and because of that gaze, we have to go to the idea of access and the intersecting pressures that come on individuals when they engage in the health system. I think that's part of your story, Katerina, really resonated to me. The money question, the time question at the very least. When we know that women are paid less in less secure work, language issues from migrant experience, less education. How important, Katerina, is to actually, for our medical system, to actually understand the reality of access when we think of, for you, women's health? And Asiel, I'm going to ask the same thing of you as well. But Katerina, how important is access when we consider the politics of health?
Access is, as we hinted at, everything, and it's something I think we don't consider when we think of the Australian healthcare system, because we think of it as universal and that it is here to catch and care for everyone, where in my own experience that is not the case. I see significant gaps in caring for people with mental illness. For my own experience alone, I write in the book that having brain scans was bulk billed, but psychiatry is not, and psychiatry is prohibitively expensive and often incredibly necessary to many of us. So there are so many barriers to access, but within that, navigating the space when there are these barriers where you are unwell is near impossible. To continually advocate for yourself in these situations where you're in a power dynamic that is seemingly beyond control is eroding, and I've started to view it as a sense of cumulative traumas, having to constantly renegotiate this power. And as I write in the essay for this the small ways to kind of try and reclaim power for myself have been uncomfortable. Something as simple as like wearing makeup, or how I dress, or or where I stand will contribute to how I'm treated. And that is something that is unacceptable. So the barriers we are facing are not only financial, but are incredibly embodied, in my opinion.
That issue of the constantly advocating, the reinvigorate, the re-traumatizing, and the constant need to reclaim power is a narrative that I think plays out in so many systems in our society. And I want to acknowledge the work that I do with practitioners in the family violence space, where that's one of the issues that we're constantly trying to address, is how do we not re-traumatize victim survivors through that court system, you know. So that really resonates. Asiel, I want to acknowledge, if I can, just before I follow on to you, that we've got a great question from Anna on the chat, and I will, Anna, I will go there, but I just want to finish, if I can, this with Asiel. You write about access. So your experience, and I really loved what you said before about the problematic way that we frame gender and pathologize gender. I think that really resonated with me. You know, what's your experience to make sure that our medical establishments talk about access and understand it, that the complexity of the systems prevent access, and those things also that Katerina talked about? What do you think are the key things we need to be doing when we engage with that medical system to change?
Oh my God, okay, here we go, another rant.
No, do not, no, please.
It's, on the one hand, I would agree with Katerina. I think we're somewhat privileged in Australia in that there is kind of Medicare there compared to systems like the US, where it's entirely privatized and the access just goes out the window, basically. But at the same time, we have this kind of dual system where you have Medicare on the one hand and private system on the other hand, which does create that socioeconomic gap, essentially. And if you've got the money for it, it's like making a private referral is 1,000 times easier compared to a public one, particularly when it comes to things like mental health, particularly when it comes to things chronic disease, chronic pain. So one of the most kind of vulnerable patients who will require ongoing episodes of care, it's the one where the kind of biggest barriers are. And on a similar note, our healthcare systems overall, at least the public healthcare systems, are organized to really look after acute episodes of care. So if you've got a heart attack, amazing, go to the AD, get seen within a few hours, get sorted out, done. If you've got ongoing chronic disease, then it becomes really, really difficult. And it's a constant fight, as Katerina very rightly mentioned, to constantly self-advocate and have to re-enter the system in many ways. And what can sometimes be difficult is in this big complex system, if a practitioner deems that this is not the space for you. So for example, I don't know, if you have a condition that gets seen in a neurology clinic and the neurologist says, this is not it, we should go to psychiatry or mental health. Sometimes what happens is that patients start kind of bouncing back and forth, and each one of those bounces is, months and months and months of delay, potentially for the condition to get worse, and it may be difficult. And again, I have to recognize that constant fight that people have to make in order to get that there. And one of the reasons that I ended up kind of going into general practice, I was initially really quite interested in psychiatry and did everything I could to get into psychiatry. But I just couldn't get my head around all the systematic gaps that were there.
Yeah.
I think it wore me down in a way that I didn't expect it to. So when I was talking to patients, to me, it just kind of, I saw their experience as systematic failures or ways that, we could have done better. That meant that.
Sorry, can I want to make sure I'm understanding, Asiel. So you were presented with a person who had an illness, but what you saw as a medical professional was actually someone whose illness was contributed to by the system. So the illness wasn't within them, it was what they were taking on board because of the systemic issues.
That's right. So if someone presented, for example, who was acutely suicidal, to my head, I was like, well, if we had a system where there was a caseworker that reached out within a time frame that we didn't have to make you wait, you know, however long to see a psychologist, that we had kind of closer systems of follow-up, perhaps this could have been avoided. And to me, just kind of wore down a little bit too much.
So apologise for my clock in the background, Asiel. Please keep going.
No worries. So to me, general practice was a little bit more of, I was very much at the forefront. I was the one that was able to advocate. And now with my patients, I try to really work with them to, if this is taking too long, or if this referral got knocked back, what are the other resources that we can access? And in a way, fight with them and not fight against them, or fight, you know, contribute to that barriers to access. It's very much about taking those barriers down.
Okay. I'm going to ask one of the questions from the chat, if that's okay. And Katarina, I might address this to you, because I think there's incredibly vital things for us to listen to the needs of those that are negotiating their health and advocating for it. I've got a question here is, do you have any practical advice, Katerina, on how we can advocate for medical professionals, particularly psychiatrists, to prioritise their duty of care in their practice, i.e. how to make them listen to someone who does not communicate in a way that they might take on as informed? So a bit in there, duty of care, listen, be informed. What would be the practical advice that you'd give to psychiatrists or the psychology stream?
So I suppose there's two kind of elements in that question. What advice would I give to someone moving into that room as a patient? And then what advice would I give to a medical professional? And they're wholly different, obviously. I think it's difficult when you go in as a patient, because there is, of course, limits to that you are constantly negotiating, which feeds into the exhaustion of how much can I push for what I need, how much can I express problems within a very limited and expensive amount of time. And within that, you find if you have a complex illness that is not understood or is rare, like myself, you find that most of that time is spent explaining what your illness is. So time to advocate is really shrunken up. So I suppose I would say there are small things we can do, but I would like to emphasize community, and that the onus is not on us as patients, but on the profession itself. And within that, I would say moving towards advocating for more accessible healthcare, putting the work in there from that place of power, and on an individual note, trying to listen without judgment and respect that the patient has the ability to narrate their own experience in their body, and trust that.
Asiel, as a person who has gone through medical training, you of course were trained to listen with a sense of understanding your power. You were trained, of course, to understand the re-traumatizing of advocacy for, weren't you? That was what you were trained in, weren't you? Along with anatomy and everything else.
Probably not, to be honest.
Yeah, really, right.
And this is why I think, or at least part of my interest is very much working in the medical education space, because the way that we currently think about medicine, and it is changing slowly, very slowly, but the way that we really think about medicine is very much those nitty-gritty anatomical management principles, medications, and you know, there's a lot to remember in there. But we sometimes don't pay, or rather a lot of the time, all of those social factors just get kind of thrown into the background, and all of those communication skills. And kind of to bring, again, feminism to bear on this medical, you know, systems, skills that are traditionally thought of as soft skills. So those listening, communication, understanding is just completely thrown out, and it's very much ad hoc, and it's more as like an optional. It'd be good if you could demonstrate those skills. If you learn them, it's good, but it's not absolutely necessary to pass or to get through. If that kind of makes sense.
That's fascinating. I mean, one of the past lives I had was I was in education, and you know how we construct ways of knowing to understand ways of learning is an incredible thing to stand back to and look at the meta, particularly when it comes to gender and our understanding of what gender is. Just want to acknowledge everyone that we've got a few more minutes before we end the formal panel, and I can see there's a few hands going up, which is so exciting, and we've got a few questions coming in through the chat. So just at about 10:15 we'll do it, but I'm just going to digress for a moment if I can. I really want to connect with what I thought another theme was that came out through your book, Katerina, which is that of identity. And you talked before about the pathologizing or the re-traumatization of the process of diagnosis. From my feminist perspective, a woman's sense of identity, when they're historically anything other than cis male, is abnormal. And we know that from testing of drugs, etc. In your book you write, and I'm going to read this, I contemplate if I can bear to add another diagnosis to a growing list. I'm beginning to feel like a collector than a person. And a question that emerged for me is, what does it mean to have multiple diagnoses? Do you then have multiple identities from multiple gazes that you then have to manage?
I think the experience of living with multiple diagnoses is that is another barrier of access to care, because it is difficult to have holistic care while navigating interactions of illness. So, for example, there's only so many antidepressants in my dosage I can take because I have a heart murmur. And sometimes testing of certain aspects can be traumatizing or anxiety producing. So there are barriers there because you also have to then navigate how much do I disclose of my mental health when I'm navigating something that is, through at least the colonial medical gaze, is seen as an entirely bodily experience. So that, I think it is an access issue. And I think also it began to feel that way, and I wrote that in the book because at that time I was doing as much reading as I could about my illness and about illness, mental illness itself. And I was being presented with a practitioner lens, and historically that has also been a white cis male lens. So I wasn't able to see voices and identities like myself. I could only see myself being written about. And when you were written about as a patient, your identity is stripped to the threat of illness. But when you write about yourself, or when I researched the lives of these different women and tried to find their own words, I was able to see that this thread is just one part of them.
Asiel, there is so much in that. isn't there?
Yeah, absolutely.
I don't know.
Down as I went along.
Yeah. What does this mean to you? Is it about we have to treat the whole person? I mean, does that, what is that? Does that even work in the system?
There were a couple of things that really jumped out at me there. First of all, acknowledging that this is, or kind of the space that we work in the medical system, is very much a colonial lens. And the way that we conceptualize about illness, and particularly the way that we conceptualize well-being, might be very different in Aboriginal, Torres Strait Islander cultures and in other First Nation cultures. Now, I don't have so far away from the expertise in that space, but I think we have so much to learn to bring that on board and really challenge just the frameworks that we operate in to begin with. Because I think a lot of it comes down to that illness narrative. When Katerina, you mentioned that when people write about you, it takes away that narrative as a personal experience and filters it through this kind of diagnostic lens, where essentially it all becomes about that illness, that diagnosis, that management. We care about what previous treatments you've had. We care about what people have you seen in the past. We care about what other systems of health you have accessed, and less so on the bigger functional picture, less on what it means for you, less so on how do you make sense of this narrative. So to me, the other thing that spoke there was the ways that I suppose meanings are imposed or meanings are imposed on that narrative through that medical, again, pathologizing lens that can sometimes be quite different from a personal narrative of lived experience. I'm not sure, Katerina, there, if I kind of misinterpreted or spoke correctly. Please feel free to correct if I didn't. Yeah. But I thought that was just such a fantastic insight.
Yeah. Katerina, do you have anything to add to that? Because we might move into... sorry, my dog's bouncing a ball underneath my chair. I do apologise. I'm getting slightly distracted trying to keep them out of the way. Do you have anything you'd like to add to that?
I was going to say, Asiel, I really liked the idea of the imposing narrative, and within that, ideas of like shame and suffering that often are imposed when you perhaps, at least for me, when I go into an appointment and there's all these assumptions around my own experience rather than listening. And when those assumptions are taken, obviously the quality of care is deeply affected and the relationship is deeply affected too.
Amazing. I'm sitting here wondering if we need to start thinking about, intersectional feminist medicine, but Asiel, I have a feeling you're already starting to, from my reading of your work, you're leading that charge as well. Are you okay to take some questions from the team and the community that's online? And just to reiterate, there's some questions that'll come through the chat to me and the team can hear it, but I want you to know I can see in front of me, I have a little box and I can see when the hands go up. So just to reiterate, if you know how to do it, you can, you go to the chat function or the people function, you open it, and there should be a little hand that you can open up as well. I can see hands coming up already. I can see them come through the chat. So as the hands start to come up, I've got a question here that I think I'm going to indulge in because I think it actually goes to the idea of what we were talking about, which is access and identity and intersectional. It's this great question. It says, and I'm Asiel, Katerina, whoever, what role do you think language, we had this conversation, didn't we, when we were prepping for today, language has in creating and solving some of the issues in this space? Is diagnostic language a barrier to care? Asiel, Katerina, who would like to comment on that first?
Well, from my perspective, particularly psychiatric and discourses around mental health, it's just such a fraught space. There's, and Katerina would love to hear your perspective on this, but you could literally send kind of a patient to two different practitioners and come up with a very different formulation depending on that. And that also sometimes dictates barriers to care. So for example, if someone has a diagnosis of a more serious mental illness, and again, that's very much defined in our kind of medical hat on and not defined by the impact, the functional impact and the day-to-day impact of that patient's lives, then it might become easier to get into certain healthcare systems. So the diagnostic language in particular is just so problematic in various different ways. The other reflection that I have on that is for people who are culturally and linguistically diverse. So, for example, my mother, who was a diagnosis of fibromyalgia, it took literally about 2 years to get there. And the reason being is her English is not very good. So when people were trying to take a history, it was very difficult to get that information across. She would describe things in ways that, you know, words that meant something else for the doctors that she was talking to. Wow. And that was a huge kind of barrier to diagnosis and therefore barrier to kind of care. So long story short, yes, it's a very problematic space, the way that used particularly in the mental health care discourse and the mental health care system.
Yeah. Katerina, any thoughts on that about diagnosis language, which I think your book really illustrates beautifully?
Yeah, I definitely am one to talk about the power of language. With the idea of hysteria itself is such a potent word. I think too, something I've seen in my own lived experience is that just because terminology may move out of fashion or out of use, that doesn't mean you will not be met with it within your own patient-doctor relationship. So there are limits to how much the change of language can help without the commitment to change within the individuals perpetuating that language use, if that makes sense.
Yeah. So
while language is wholly important, and I really advocate for the use of neutral, non-emotional language that moves away from disability and mental illness as an idea of tragedy or suffering, I think that it's also important to move beyond language in how we practice respect with one another, in moving away from stigma.
Here. Katarina, here. We have a question. Isabella, I've seen you have your hand up for a while. I'm going to, if you're comfortable, unmute you. Isabella, did you want to ask your question?
Yeah, I'd love to. Did you want my camera on for this?
It's completely up to you. It's completely up to you.
Great. I've got a bit of a curly question, and the reason I wanted to articulate it verbally is I'm still working it out myself, but I'm a mixed race woman with a disability, so the health system's definitely taken its toll on me in a personal way. And now I'm actually training to become a remedial massage therapist, which is a very an industry that's fought very hard to be seen in the medical clinical world, as opposed to being part of something like alternative medicine, for example. And I also come from a very scientific family. My dad was a scientist. So I have a very strong belief in peer-reviewed, double-blind, evidence-based medicine. And I think professionally, if I was to move into an allied health role, that would be a really important consideration. However, the further I get into my study, the more I realise how patriarchal and colonised and how many different politics play into the things we are told now are mainstream medicine and are, things that are well enough proven and proper, in inverted commas. I should have put my my video on so you could see all the inverted commas I'm doing. Got bunnies jumping all over the place with my fingers. But and then I also see in my community so many of my peers who are also from marginalised groups leaning on alternative medicines because they've had such terrible experiences in the mainstream system. And then these alternative medicines in turn, I find have issues around racism because it's white people running ayahuasca retreats or whatever. And you just think...
see Asiel smiling to himself.
And you can imagine the look on my teachers' faces when I try and bring this up at RMIT, which is otherwise a wonderful university. But this intersectionality of this intersection of mainstream medicine failing anyone other than cis men because they're not included in studies, versus all the problems that come with unproven, untested alternative medicine that's often cheaper and appears to present a more diverse understanding. I'd love to hear what the panelists think about trying to navigate that space.
Yeah, so fantastic. Thank you, Isabel, and thank you for Isabel for sharing your experience. Asiel, I think what we're doing was we're hearing someone who's in the process of learning, so is open to noticing as well, talking about the opportunities of intersectional and understanding, but the complexities in a science-based model. And I would say also listening between the lines, I should say, anxious for change, knowing how important it is. Katerina or Asiel, do you have any comment on that? Support for Isabel?
I would say it's quite complex. I'm not sure if I have a very good answer for it. I would completely agree with pretty much everything that you just mentioned. I think what we need to do, or to kind of direct the conversation towards, are really those broader systemic kind of factors around it. And to me, I'm still trying to kind of put my head together on this, because there's so many other kind of complex ethical nuances that can go into it. So we talk about, evidence-based and trying to include more marginalized voices into that. How do we go about it in doing so in a way that's kind of ethical? We'd really have to, and this is coming more from a research academic type of background, really inviting people and community into the design of the research itself. So I suppose the thoughts that I'm trying to collect together are more around making sure that the people whom you're trying to work towards are included into that process. It's still such a long way to go, and it depends a lot on what kind of area you're working in. But for example, I'm just thinking in something like the remedial massage space, if you want to take it around an evidence-based type of background, perhaps making sure that Aboriginal, Torres Strait Islander voices are included in that, so you have that, or you're aware and challenging and critiquing that colonial lens and seeing how that study design could be made in order to incorporate those perspectives. There's, let's say, some flexibility in this space, but we have to contend with a lot of just, kind of historical notions about what good research and good evidence base is. The other thing that I think just medical science has to contend with significantly is how we prioritize different types of evidence and to what extent. So usually we see those big qualitative type of studies being significantly more predominant, whereas the qualitative studies which look at the richness of lived experience is usually kind of a little bit poo-pooed and thrown to the side. So there's still a lot of work that we have to do to challenge kind of those assumptions about what makes a good solid evidence base and how do we use it. Again, another bit of a ramble for you, but Katarina, I'd be really interested to hear your perspective as well.
Yeah, I love the ideas you brought up, Asiel, about qualitative and quantitative. And within that too, I think an issue around moving away well, not moving away, but not trusting qualitative evidence and lived experience, is that within that, that means we're not trusting that people have the ability to know what the best care would look like for them. And within mental illness especially, I think that an individual's understanding of their illness and themselves needs to be considered, and that people do know what the best care looks like for them, but they are not given the assistance or the many accessibility issues we've talked about today, like financial cost, impact their ability to be empowered to seek their own treatment path. So I think it comes back to valuing somebody's ability to know what their body needs and care for themselves, and supporting that.
And again, we hear these themes of listening as well. I mean, my you know, and the co-design of research, Asiel, that actually excites me. We have another question from Jax. Jax, would you mind just unmuting? And if you feel comfortable speaking, it's up to you if you'd like to turn your video on, Jax, but you do not need to. Jax, over to you.
Sure, hello, and thank you so much for such a wonderful and thought-provoking discussion. It's been really lovely to listen to it. I'm a queer wheelchair user, so I do a lot of deep thinking about what this space means and how to navigate it. And I'm really interested to hear, Asiel, your reflections on practicing in a pandemic, and how you signal to somebody that, and it's definitely how I've found you, that you're a safe and supportive and intersectional thinker, and you're open to acknowledging the violence of the medical profession on people, but how you do that in a telehealth consult that may only go for 15 minutes, for example, acknowledging the time pressures on you in that space, when maybe somebody can't see all the fabulousness that you bring to that consult in the same way they might if they were meeting you in person, how you let somebody know that you are listening and intersectional and creating a safe space for them at this time.
Amazing question. Thank you, Jax. Asiel, just fix that telehealth during the pandemic challenge, please. Yeah. Thank you.
And I have to say, a lot of my thinking around kind of intersectionality, particularly when it comes to disability, is also so much based on Jack's works before. So thank you so much for the work that you're doing already, Jax, in this space, because it's so brilliant. It's been really challenging in telehealth, or actually, let me take a bit of a step back. It's had its pros and cons in a certain way. I think telehealth really revolutionized certain aspects of access. So for example, we used to have people that would drive, 3 hours to the clinic just for, a script and a relatively simple review. And now they can do that from home. Similarly, lots of individuals who have, severe impact on their mental illness, who may find it a little bit too challenging to make the trip physically into the clinic, or from the trans and gender diverse community who just feel a bit safer not having to expose themselves to potential violence that may kind of experience on the way. So it certainly helped certain elements of access around that. The communication side of things became a little bit trickier, and it took quite a bit of time to get used to, because people interact over the phone and online a bit differently than what they do face-to-face. So a lot of the non-verbal cues are lost. A lot of the kind of holding physical space that makes you, makes the patient aware that you're actually listening can sometimes be a little bit tricky to convey. And similarly, I found that I was also a little bit more distractible because while I was on the phone, I could kind of write notes and print scripts and do other bits and bobs at the same time, which I typically wouldn't do if someone was kind of face-to-face with me. I suppose the way that we eventually, or at least for me, came across that was to really make sure that I held space in that telehealth consultation. So instead of those nonverbal cues, just making sure that I communicated, even through just, yes, go on, that people were kind of being listened to, lots of open silences, just to make sure that, again, that person has the opportunity to disclose everything they might want to disclose. The other thing that also helped was that we had to swap to bulk build only for a period of time. And even though the time pressures were just always something that's kind of there, or being able to kind of see people multiple times rather than just trying to sort everything out in one go. So I would say there were some barriers there were some challenges, but I think overall there were lots of really great opportunities. And in my opinion, it'd be really great for telehealth to continue to be funded by the government in the way that's currently funded, or even more so. So those accessibility barriers are always, or rather, so that it's always an option there for people who might have other accessibility barriers.
Great, Asiel, thank you. And again, this idea of deliberately listening and holding the space to let people speak. Katerina, have you been using the telehealth?
Yeah, I was going to throw it back to Katarina.
Yeah.
I would love to hear how you navigated that space, because it's all well and good for me to be like, yeah, yes, I'll do all these things, but does it actually translate into practice?
Absolutely, yeah. Katerina.
Yeah, I too agree, Asiel. I think telehealth is something that should be continued for the reasons you spoke about. The access itself has been something that's really helped. But in addition to that, the use of telehealth has allowed me to maintain a sense of safety, being at home within your own space and being able to access care when you have had perhaps traumatizing experiences within the healthcare profession. That has helped mediate that. So I think it's something like I wholeheartedly believe should continue and hope that is continued with funding.
Oh, sorry.
I'm on mute. 1, 2, 3. You're on mute. I just want to encourage people to put up their hands and continue the conversations come through. We've got a couple of questions. Katerina, I'm going to ask you this one. It's all right. There's been a question come through that say the panel mentions that sometimes the problematic writings of Freud or even Sachs. What authors should practitioners be reading? Katerina, what do you think?
So I think it's really important that practitioners are reading own voices books, and within that, lived experience from a diverse group of experiences in different places and of different identities to understand. I suppose understand such an interesting word, isn't it? Because you can never understand truly what it is to exist within a body, but to try and mediate your own responses to somebody else's body so that you were navigating the relationship with respect. So there are so many incredible writers in Australia with lived experience, and I always say to start with Carly Finlay's edited collection Growing Up Disabled in Australia, because from there you can move around and follow the writers you enjoy. I also myself was really deeply impacted by Elin Sachs's account of schizophrenia in The Centre Cannot Hold, and her work since as a law professor talking about physical and chemical restraints in psychiatric care. So I think there's a lot. Once you look, you will find so much thoughtful, generous accounts of lived experience.
Sorry, some reading lists emerging, I see. Asiel, you held up one of the books that Katerina spoke of. What else would you recommend?
Yeah, but the was just saying there's kind of hold here.
Yeah.
The writings from Jack's, actually, there's quite a few essays that are online that I would highly recommend as well. Carly Finlay, as you mentioned as well. My perspective is a little bit different because I often pick it up from like a medical practitioner's kind of point of view. So I tend to pick up books that are from medical writers. Having said that, I tend to pick up books from medical writings that are critiquing the kind of broader structures around medicine. The other writer that has been quite influential for me is Andrew Solomon, The Anatomy of Depression, someone with lived experience that has a really comprehensive systemic historical view around the ways in which we talk about depression, as well as an interweaving of his own personal experience with it. Is absolutely brilliant and I would highly recommend. The other writer which I often enjoy, and more because of her writing style, is Karen Hitchcock, who is another Australian writer. Again, this is more coming from a medical lens rather than from lived experience. So I would essentially direct you to all the fantastic recommendations that Katerina had just made. Because I agree, I think we should prioritize kind of lived experience in our reading and writing.
Yeah. Someone's just put up in the chat line, sorry, I missed the book titles. I'm just wondering if there's someone from the Writers' Festival and I who remembered those titles maybe. Oh, there we go. There's going to be a recommended list. So that's fantastic. We've probably got time for 2 more questions. There's one really great one about navigating the system that's come up, and I just want to go to that. And then Fernanda, I'll go to you to finish off. And Jax has said, own voices hashtag on Twitter. Someone's just sort of said, look, I have chronic back pain and I've not found any doctors or therapists that have been able to help. And this is about the chronic pain that you talked about, Asiel. How do you suggest going about finding those decent medical professionals who operate respectfully? And my request is maybe if we answer this question as effectively and efficiently as we can, because I do want to go to Fernanda. Thanks, Asiel.
I was going to suggest it's really hard because unfortunately there's not like a centralized system that you can just go to and be like, this person is
www.respectfuldoctors.com.au.
Yeah, that's right. My main suggestion is really for the GP to be the anchoring point. I feel like if you find a good GP who's able to advocate for you, it just makes things a little bit easier because they can do some of that homework and look around or have already a good referral kind of pathway within their networks. But chronic pain in particular is really, really challenging. And again, just because our healthcare system is not necessarily well equipped to deal with it. My first and foremost suggestion would be to find a good GP that deals with chronic back pain that can kind of fight alongside and advocate on your behalf as well. Where that GP might be, it's a little bit tricky about having to kind of shop around for it a little bit more, but it's such a challenge.
Thanks. Katerina, what advice would you give?
So I found it really helpful to go to disabled peer networks like Facebook groups. I'm a member of Chronically Fully Sick, and there we talk about where we've been treated with respect and listened to and received proper care. So I would suggest reaching out to fellow patients who have similar lived experience because they are such an incredible and generous wealth of knowledge.
Great. That's great. Thank you so much. And we're going to just do one more question if I can. Fernanda, I'm going to ask you to unmute. It's up to you if you want to put your screens on. But Fernanda, do you want to ask your question?
Sorry, that was it. I accidentally wrote it in the chat and then I realised I was meant to raise my hand. So
well, that's fantastic.
You've already dealt with it. Thank you.
Oh, wonderful, Fernanda. Thank you. And we've got some more comments coming through the chat about some of the quotes. Sandy Jeff's flying with paper wings is an amazing description of living with schizophrenia and the mental health system. Look, I think I just want to close, if I may. It's such a rich discussion, informed by lived experience, informed by the reality of the world that we live in. And I think for me, the gift of this session has been that with regard to the politics of health, we're hearing these things about listen, self-determination, the challenges of diagnosis language. And I like someone, I think it was who said before, I too am from a family of medicos, and understand the gift of the discipline, but the trauma that it can lay. And I really want to end, if I can, on the words of Katerina, where she talked about the need to advocate and the constant need to advocate and represent yourself. And I want to recognise that there are those people that can do that, but that for all of us, we've got to make sure we're advocating for those people who can't or who the system won't listen to. Thank you, everyone. I do want to say a very heartfelt and warm thanks with deep gratitude to Katerina Bryant for her book, for her work, and for her ongoing commitment as an artist, which at this time is challenging, and recognise that commitment. And I also want to thank the great Asiel Adan Sanchez for his commitment to represent the needs of community here locally and across the world, and to improve our health service to better recognise the diversity of our world. So thank you so much, and I really appreciate you both, and look forward to speaking to you again soon.